Hello and welcome to my YouTube channel, AnatomyMentor. Today we will be discussing the topic which is the development of the skull. So here I've opened my PowerPoint slide in front of you, and the learning objectives for today's topic are that at the end of this session, you should be able to describe the embryological origin of the neurocranium and the viscerocranium, which are the two basic parts of the skull. And also, you should be able to describe the salient features of a newborn skull and postnatal growth of the cranium. Also, we will be talking about the cranial abnormalities like cranioschisis, craniosynostosis, and microcephaly. So let's start with today's topic, beginning with the definition of cranium. What is cranium? Well, cranium is our skull. The medical terminology for our skull is the cranium. And as you can see over here in this diagram in front of you, there are two main parts of our cranium. The first part is the neurocranium. This here is the neurocranium, the part which is covering the brain from all the sides, on the top as well as below and sideways. So this part of the cranium is known as neurocranium because it is encasing the brain, and it is like a box which is surrounding the brain, so it can be called as a brain box. Then comes the second part of the cranium, which is this part over here, which has been highlighted in blue. This is the viscerocranium, and this is also known as splanchocranium, which means facial skeleton. So remember, the skeleton of the face is considered to be a part of the skull. Now, how many bones are there present within the cranium? Well, first we will look at the number of bones which are present within the neurocranium or the brain box. These are 8 in number. So remember this number, which is number 8. We have 8 cranial bones. Now, here is a very simple color-coded diagram of an adult skull in front of you. And you can see over here, if you follow the laser pointer, that anteriorly the bone which has been colored in yellow is the frontal bone. And then behind the frontal bone in blue represents the parietal bones. And then posteriorly, that is at the back side of our head, we can see the occipital bone, which over here is in green. On the lateral aspect or side of the skull, you can see this orange colored plate, which is the temporal bone. Also, anterior to the temporal bone in purple, you can see the sphenoid bone. And then if you look over here within the cavity of the eyeball, or you can say over here, this anterior hole, you can see the red portion, which is representing the ethmoid bone. So these are the bones which are present within the neurocranium or the brain box. Now, the number is 8 because the parietal are paired, and you can see over here the temporal are paired. So 2 bones are paired, that is the parietal and temporal. These are 2 each, one on either side, whereas the rest of those, they are unpaired, giving us a total of 8 bones in the neurocranium. Now, what about the bones which are forming the viscerocranium or the facial skeleton? Well, these are total 14 in number. Here you have to remember the number which is 14. In this case, 2 of the bones, they are unpaired and they're present in the midline. One of these is the vomer, which you can see within the nasal cavity. And then in purple, you can see our lower jaw bone, which is the mandible. It is also an unpaired bone. Other than these, the rest of the bones in the facial skeleton, they are all paired. These are the zygomatic, which is colored over here in green, or the cheekbones, in simple words. And then anteriorly, the maxilla bones, these are also 2 in number. They are paired. They are forming the bones of the upper jaw. Within the nasal cavity, you can also see the paired inferior nasal conchae. In light green, they have been highlighted in this diagram. And then behind these, you can see in red over here, the paired palatine bones. If we look at the upper part of the bone in the region of the nose, we can see the 2 paired nasal bones as well. And in the inner aspect of the eyeball socket, you can see this lacrimal bone. These are also 2 in number, and so they are present in the inner aspect of the eye socket, and they are also paired, and they are over here in light blue. So the total number is 14 in the facial skeleton, in which 2 bones are the unpaired bones, vomer and mandible, whereas all the other, they are paired, giving us a total of 14 bones which are forming the splachnocranium or the viscerocranium. Okay, so let's just look at these bones that I've shown you in simple diagrams now in a 3-dimensional digital model, and we can count these bones as we go along, and we can identify these bones in that 3-dimensional digital model of the skull. Okay, so now I'm sharing with you the digital model of the skull or the cranium. And now we're going to count the bones which are present within the skull. And like I told you, we can divide this cranium into 2 main parts. Here, the upper portion, which is known as the neurocranium or brain box, is the part which is surrounding and protecting the brain. And then the lower part, which is the facial skeleton, that is the viscerocranium. So remember that the neurocranium has a total of 8 bones, whereas the viscerocranium has a total of 14 bones. So let's count these bones as we go along, and I would like you to just follow this hand pointer present on the digital model. Well, this here is the frontal bone, which is the anterior unpaired bone of the neurocranium. And posteriorly, if we look at this skull from behind, we can see this here is the occipital bone, which is also an unpaired bone present in the midline. And between the occipital and frontal bones, these here are the 2 paired parietal bones, which you can see from the superior aspect of the cranium. And if we look at it sideways, we can see this here is the parietal bone. So the parietal bone are 2 in number, they are paired. And on the side of the skull, you can also see this here temporal bone, which is also a paired bone. There's going to be 1 on either side of the skull. Anterior to this temporal bone, right over here, you can see on the external aspect of the skull, this here is the sphenoid bone. Now, sphenoid bone, keep in mind, is an unpaired bone. It is a butterfly-shaped bone when you look at it from the interior aspect of the skull. Externally, you can see it over here on the lateral aspect of the skull. And you can also see that this here is the sphenoid bone, which is visible in the lateral wall of the bony orbit. Let's look at the medial wall of the bony orbit. Right over here, you can see the ethmoid bone, which is also an unpaired bone, which is present within the neurocranium. So the total number of bones in the neurocranium are 8, because there is the number 1, the frontal bone, a single unpaired bone. Number 2, the occipital bone, which is also a single unpaired bone. Number 3, the sphenoid bone, which is single and unpaired. Number 4, you've got the ethmoid bone, which is also single and unpaired. And then 5 and 6 are these paired parietal bones, and 7 and 8 are the paired temporal bones. So this gives us a total of 8 bones within the neurocranium. Now let's look at the facial skeleton or the viscerocranium. It's the opposite in case of the viscerocranium, because in the neurocranium we saw that 2 bones, they were 2 bones which were paired. But over here, there are actually 2 bones which are going to be unpaired. What are those 2 unpaired bones? Those are the mandible bone. You can see over here, the mandible is the lower jaw. It is present over here as this is a single bone. And also in the midline of the nasal cavity, you can see the vomer bone, which is a vertical plate of bone and an unpaired bone. So these are the 2 unpaired bones within the facial skeleton or viscerocranium. The rest of the bones in the facial skeleton, remember, are paired, namely the zygomatic bones. You can see over here, these are the paired zygomatic bones. They are forming, in loose terminology, you can use, that is the cheekbones. And then you can see over here the maxilla, which are the paired bones of the upper jaw. Within the nasal cavity, in the lateral wall, you can see the inferior nasal conchae, which are paired and they're present within the lateral wall of the nasal cavity. Also, over here, this is the nasal bones. These are the nasal bones. These are 2 in number and they are paired. Let's look at these bones over here in the medial wall of the orbit. As I showed you over here, in the medial wall of the orbit, you can see this here is the lacrimal bone and the lacrimal bones. So they are paired, one in either side of the medial wall of the bony orbit. And also, if we want to look at the palatine bones, which are the paired bones, we can see them in a much better way from the inferior aspect of the skull. We can see these are the paired palatine bones. So this gives us a total of 14 bones in the viscerocranium or the facial skeleton, out of which the unpaired ones, remember, are the vomer and the mandible, whereas all the other bones of the facial skeleton, they are paired bones. Okay, so now we can go back to our PowerPoint slides. So coming back to our PowerPoint slides, let's just summarize what I've just shown you in that three-dimensional model of the skull. This is a summary of the bones, which you can see a total 8 bones which are present in neurocranium. And then you can see the facial bones, which are a total of 14 bones in the viscerocranium, right? Now, when we talk about the neurocranium or the brain box, the part of the cranium which is surrounding and encasing the brain, this neurocranium is further also divided into 2 parts. The part which is forming the top and the sides of the skull, that is known as the skull cap or the calvaria. And this is the part of the cranium which is formed by the method of ossification, which is the intramembranous method of ossification. So it is also known as the membranous neurocranium. Whereas the other part of the neurocranium is that part, those bones which are forming the base of the skull. And this is formed by the intracartilaginous method of ossification. And so this is also known as the cartilaginous neurocranium or the chondrocranium. So here to differentiate these 2 further subdivisions of the neurocranium, on the left, you can see these are the bones which are forming the tops and the sides of the skull. So this is the skull cap, or this is, you could say, the membranous neurocranium. Here is the part which is forming the base of the neurocranium. And let's look at these bones from inside. These are the bones here forming the base of the skull, and therefore this is the cartilaginous neurocranium, also known as the endochondral neurocranium, because this is the part which is formed by intracartilaginous method of ossification. So those bones which are forming the neurocranium, which we just talked about, the 8 cranial bones, if we look at those bones from the inside of the skull, like I told you, here in yellow, you can see this is the sphenoid bone, the butterfly-shaped bone, which has a body in the middle, and here are the lesser and then the greater wings of this sphenoid bone. So keep in mind, this is a single unpaired bone. And anterior to that in the midline is the single unpaired cranial bone, which is the ethmoid bone. And on either side of this ethmoid, you can see these portions of frontal bone. Here you can see the temporal bone. And on the side, you can see the parietal bones, which are paired, and posteriorly the single unpaired occipital bone. So these are the bones, the same bones which I had shown you in that 3-dimensional model. These bones, this is how they appear from the inner aspect of the skull. Now let's talk about first the membranous neurocranium, that is the skull cap. This is the part which is present on the top and sides of the skull. And over here, these are the plates of bones. You can see the frontal, the parietal, and occipital bone, which are formed by a method which takes place during intrauterine life, that is the intramembranous ossification, in which the membranous tissue appears first, and in later stages of development, it is replaced by the bony or osseous tissue. So this is a diagram showing us a 3-month-old fetus, and you can see this appearance of the bony spicules from the primary ossification centers, that is those centers of bone growth which appear before birth, and gradually they will form the flat bones of the skull, that is the frontal, parietal, and occipital bones. Now, when we talk about the embryological origin of the skull, you have to just remember that there are 2 basic tissues of origin from which the skull is derived. The first tissue of origin, they are the neural crest cells, and the second tissue of origin, that is the paraxial mesoderm. And when we say paraxial mesoderm, it means in the head, we are talking about somatomeres and the occipital somites. So this is a very simple color-coded representation. This is a diagram which is showing us that the visceral skeleton and the bones which are present in the anterior part of the cranium, that is the frontal bone, sphenoid, and the squamous part of temporal bone, they are the ones which are derived from the neural crest cells. Their tissue of origin is neural crest cells, and these are the bones which are represented in the blue color. And in the posterior part of this diagram, the bones which are represented in the orange color, that is the parietal, petrous part of temporal, and the occipital bone, these are the ones which are derived from the paraxial mesoderm, that is their tissue of origin. So this is an easy way to remember the tissue, the embryological tissue, which is going to form the bones of the membranous and the visceral cranium. Now we come to the newborn skull. What are some essential features which are related to the newborn skull when we are especially talking about the membranous neurocranium? Well, keep in mind that there are present the joints or sutures between the flat bones of the calvaria or skull cap. Now, these sutures, they are filled with the dense connective tissue, so they are fibrous joints, and this allows a certain degree of mobility of the flat bones. Remember the point where more than two bones meet, that is known as a fontanelle. There is a certain space over there, and that is a fontanelle, and we will look at that in the diagram in this slide. So here in diagram A is a superior view of the neurocranium, and in diagram B is the lateral view of the neurocranium, and the skull that we are now looking at is the skull of a baby, right? So let's look at this newborn skull, and in the newborn skull, like I said, the flat bones which are forming the cranium, they're not yet permanently fused to each other, they're not permanently joined to each other. There is some or very slight, you could say, laxity between these flat bones because of the presence of these joints, which are the fibrous joints. They're filled with dense connective tissue, and these joints are known as the sutures. This is what they're called. These are the sutures between the flat bones of the skull. So this here is the coronal suture. It is present in the horizontal plane, and it is present you can see over here between the frontal bone anteriorly and the two paired parietal bones posteriorly. Also, I would like you to notice that this here is the metopic suture. This is a suture which is present between the two halves of the frontal bone in the newborn skull, but it disappears as the child gets older. So in an adult skull, you wouldn't see this metopic suture. So here in the coronal plane is the coronal suture, and over here in the vertical or sagittal plane, you can see is the sagittal suture. The sagittal suture is the one which is present between the two paired parietal bones. And posteriorly between the two parietal and occipital bone, you can see this here is the lambdoid suture. Now, what about the fontanelles? Now, what are fontanelles? Fontanelles are the points where more than two bones meet. So you can see the two parietal and frontal bones, they're meeting at this point over here, and there is a space over here. This space is now known as the anterior fontanelle. Similarly, where the two parietal and the occipital bones meet, there is a smaller space which is known as the posterior fontanelle. There are total 6 fontanelles, because on the lateral aspect of the skull, you can also see the anterolateral or sphenoidal fontanelle. This is the one which is present between frontal, parietal, and the, you can see the sphenoid bone over here. And similarly, you've got the posterolateral or mastoid fontanelle, which is present between parietal, occipital, and the temporal bones. So these fontanelles, these are going to be paired, the anterolateral and posterolateral ones. So you've got a total of 4 of those fontanelles plus the single anterior and single posterior fontanelle, giving us a total of 6. And these fontanelles, remember, they are going to close after birth. And you can see the posterior fontanelle, it closes about 3 months after birth, whereas the anterior fontanelle, this closes about around the middle of the 2nd year of postnatal life. So these are the fontanelles and these are the sutures visible in the skull. We can also talk a little about the metopic suture. As I told you, this is the suture which is dividing the frontal bone into 2 halves, and it passes from the bregma. The bregma is the point of union of the sagittal and coronal sutures. It passes from the bregma to this here nasion, which is present over here, just adjacent to the nasal bone. This metopic suture might be incomplete. Remember that the newborn skull has this metopic suture, but it closes between 3 to 9 months of age. It is one of the earliest sutures to close, to fuse, but permanent obliteration of the metopic suture, that takes place by about 7 to 8 years of age. Now, the clinical significance I would like to mention over here of the metopic suture is that in rare cases, there might be persistence of metopic suture in an adult skull. This becomes clinically important when that metopic suture could be mistaken for a fracture of the frontal bone. So we have to keep in mind this anatomical variant. What is molding of the cranium? Now, molding is an interesting process which takes place during the passage of the baby through the birth canal of the mother at the time of parturition. Because of the softness of the flat bones of the skull and also because of the presence of loose, or we could see the connective tissue which is present between these skull bones, this facilitates the slight overlapping of the bones of the cranial wall, especially the parietal bone, they are paired. So one parietal bone slightly overrides the other one. And there's also a certain change in the shape and flattening and lengthening of the other bones. So this facilitates the passage of the baby through the birth canal of the mother. But keep in mind that this process, which is known as molding, is a normal process, and the bones, they return to their normal position after a few days after birth. Now, what happens to the skull? What changes take place after birth? Well, the size of the skull cap or calvaria, remember, is greatest during the increase in size. The increase in size of calvaria is greatest during the first 2 years, because this is the time when there is going to be most rapid growth of the postnatal brain. And these calvaria, they normally increase in capacity until about 16 years of age. Now, here's an interesting fact that in some cultures, the normal growth of a child's skull can be distorted. It is distorted by applying force to create flat, elongated, rounded, or conical shapes. So although this it can have a negative impact on the brain growth and development, and it is a practice which should be avoided, yet in certain cultures and in certain parts of the world, this is something which is done artificially induced. Pressure is given to different parts, pressure is applied to different parts of the skull, and that creates a certain specific shape of the skull. So if you're interested in reading about that, I've shared a link to an article which was published in 2021. This is a study which was done on neonates in Ghana, and how the mothers over there, they actually mold the shape of the cranium postnatally. Let's just discuss the clinical correlate, because right now we are talking about the cranium, and we just saw that molding of the cranium is a normal process, but in some cultures this is artificially induced. Similarly, in some cultures, what happens is that in certain religious practices, what happens is that they they insert a metal cap on the skull on a child, and that restricts the expansion of the calvaria, the growth of the calvaria, causing a head size which is going to be smaller than normal, and that condition is known as microcephaly. And microcephaly, it is going to obviously affect the growth of the brain. It will retard the growth of the brain. So this is something that you should be aware of, which is done in certain parts of the world. Now that we have discussed membranous neurocranium in detail, we are now going to come to the cartilaginous neurocranium. Remember, this is the part of the cranium present in the base of the skull. It is further divided, we can further divide it into two parts, the precaudal chondrocranium and the caudal chondrocranium. Now, what is the precaudal chondrocranium? Precaudal chondrocranium means those bones which are forming anterior to the sella turcica, and these are the bones which are derived from neural crest cells. And the caudal chondrocranium are those bones at the base of the skull which are present behind or posterior to the sella turcica, and they are the ones which are derived from the paraxial mesoderm, and this is known as the caudal chondrocranium. So there are two parts of the base of the skull, those bones which are present anterior to sella turcica and those present posterior to sella turcica. The landmark here is sella turcica. This is simply the hypophyseal fossa within which the pituitary gland is present in the basal region of that neurocranium. So why do we consider this as the landmark? Well, we can see over here, this is a very simple diagram showing us the early stages of embryonic development. And here, the part which you can see is the rod-like structure in pink. This is the notochord. So if you recall from the initial lectures of embryology, the notochord was a midline rod-like structure which gives some rigidity to the embryo. It appears in the early stages of embryological development. It disappears later on. But this notochord, you can see anteriorly, its tip over here. This is the part where it is, you could say, adjacent to or coming in alignment with the sella turcica. So the part which is anterior to this superior part of notochord, that is the precaudal chondrocranium, and behind it would be the caudal chondrocranium. So let's now look at the skull from the interior aspect. From the inner aspect, we are looking at the bones present in the base of the skull, and we can see that this here is now the sella turcica, that is the pituitary fossa, which contains the pituitary gland. And the bones present in base of skull anterior to this, these here bones which are colored in blue, they are derived from, as I told you, the neural crest cells. Whereas those bones which are present posterior to the sella turcica, they are colored in red, and you can see these bones, they are derived from the paraxial mesoderm. So what are these bones? Well, anterior to the sella turcica, this here precaudal chondrocranium, because it is anterior to the superior part of notochord, these are the lesser and greater wings of sphenoid and the ethmoid bone. These are the bones derived from neural crest cells. This is the precaudal chondrocranium. Here in red, which are present behind sella turcica, that is the caudal chondrocranium derived from the paraxial mesoderm. This is the basal part of the occipital bone, and also you can see the petrous part of the temporal bone. So these are the caudal chondrocranium. When we're talking about bones which are going to form in the base of the skull, I told you these bones are formed by endochondral or intracartilaginous ossification. So this means that initially the pieces of cartilage appear, which are then in later stages going to be replaced by bone. Now, what are the cartilages which appear in the early stages of development? They have specific names. So let's look at those cartilages which appear in the early stages of development in the base of the skull. This here in the midline is the trabeculae cranii, which is going to form the ethmoid bone. And then you can see this here is the hypophyseal cartilage. It is going to form the body of the sphenoid bone. And you can see the paracaudal cartilage, which will form the basio-occiput. And you can also see over here on the lateral aspect, these are the otic capsules, which will form the temporal bone. Let's summarize the cartilages in the base of developing cranium. If we summarize them, we can remember them in a much better way. So the paracaudal cartilage forms, remember, around the cranial or superior aspect of notochord, forming the basio-occiput. The hypophyseal cartilage forms around the developing pituitary gland, and this will form the body of the sphenoid bone. The trabeculi cranii diffuse to form ethmoid bone. Nasal capsules also develop around nasal sacs, and they contribute to formation of the ethmoid bone. Ala orbitalis is a piece of cartilage which appears and forms the lesser wing of sphenoid bone. Otic capsules, as I showed you in the diagram, they develop around otic vesicles, and they form pitris and mastoid parts of the temporal bone. So here are a few other diagrams which are showing us these plates, these cartilages which appear initially. That is the ala orbitalis, which will form the lesser wing of sphenoid. Here you can see the ala temporalis. You can see the hypophyseal cartilages, which are going to form body of sphenoid, the trabeculi cranii, which will form ethmoid bone, also the otic capsule, which is going to form the temporal bone, and the paracaudal cartilage, which will form the basio-occiput. So these are the cartilages which appear in the base of the neurocranium. Now that we have discussed the neurocranium, we have talked about the brain box. Now we're going to come to the second part of the cranium, which is the viscerocranium or the facial skeleton. Viscerocranium. When we talk about viscerocranium, remember the bones of the face are formed mainly by the first two pharyngeal arches. If you recall from the previous lectures of embryology, pharyngeal arches are the bars of mesodermal tissue which appear in the head and neck region in the 4th to 5th weeks of embryological development. So they are about 4 to 5 in number, and the first two, they contribute to the formation of the facial skeleton. So here is our first pharyngeal arch. The first pharyngeal arch has further two portions, which are the maxillary process and the mandibular process. And then comes the second pharyngeal arch, and then you can see the third and then the fourth, which are less prominent. Now, we are focusing on first pharyngeal arch, so it has two processes, a dorsal maxillary process and a ventral mandibular process. The maxillary process forms the maxilla bone, the two paired, you can see these maxilla bone of the face, the two paired zygomatic bones of the face, and on the side of the skull, you've got the squamous temporal bones. Whereas the mandibular process of the first arch forms our mandible, which is the lower jaw, and also these tiny bones in the middle ear cavity, that is the incus and malleus. The second pharyngeal arch forms a stapes, which is the third tiny ossicle bone in the middle ear cavity, as well as the styloid process, which is present on the side of the skull, the lesser horns and upper parts of the body of hyoid bone. So hyoid bone, this is a bone which is present in the upper part over here in the neck region, and it's formed in partly by the second pharyngeal arch. This is a very good color-coded diagram from Langmans, and this is showing us over here the parts of the bone which are represented, the facial bones in orange are those parts which are derived from the first pharyngeal arch. So you've got the maxilla and the zygomatic, the squamous temporal, and the mandible bones. And those in blue, that is the stapes and styloid process, these are the bones derived from second pharyngeal arch. You can see that the incus and the malleus, they are derived from the first pharyngeal arch. This is a similar diagram. It's just now showing you in Roman numerals the numbered pharyngeal arches 1, 2, 3, 4, and 6. So here is arch number 1 forming the mandible around the Meckel's cartilage, which will later disappear. This Meckel's cartilage will later disappear, and the malleus and incus, which are also derived from first pharyngeal arch. Second pharyngeal arch is forming the stapes, the styloid process, and also styloid ligament, lesser horn of hyoid bone, and upper part of the body of hyoid bone. The third pharyngeal arch is forming the remaining parts of hyoid bone, and fourth and sixth are contributing to formation of laryngeal skeleton. So when we talk about the facial skeleton, we know that when a baby is born in the early years of life, there are certain differences in the facial skeleton from the skeleton of an adult. There is a small appearance of the face in the newborn because of the underdeveloped nasal cavities, underdeveloped maxillary sinuses, and also underdeveloped upper and lower jaws, the temporary or deciduous teeth have not yet appeared. So these, all of these, they point to the changes from the adult skull. And this gives a babyish look to the face in the initial years of life. So here is a comparison of the adult skull with the fetal skull. On the left, you can see the adult skull, and on the right, you can see is the fetal skull. And we can see the difference. There is a disproportion over here of the vertical extent of the face. So what we're going to do, we take this parameter, a simple measurement, which is taken from the lower margin of the orbit to the lower border of the mandible in the adult. And if we draw a vertical line from these 2 points, this vertical line will be about 3 times the diameter of the orbit in case of an adult skull. But when you look at a fetal skull and you look at the same parameter, that is from the lower border of the orbit to the lower border of mandible, we can see that this in vertical length is about nearly equal to the diameter of the orbit. So this gives the babyish appearance of the skull, and you can see that here the jaws are underdeveloped and the teeth have not yet appeared. And the maxillary and nasal sinuses, they're all, the maxillary and frontal sinuses, they're all underdeveloped. And all of these factors, they contribute to the difference in the appearance of the newborn skull from the adult skull. And another difference, you can see the metopic suture over here, which is not present in the adult skull. Now that we have discussed the basic anatomy of the membranous neurocranium, the cartilaginous neurocranium, as well as the viscerocranium, and the development of these parts of the skull, let's look at some cranial anomalies. When we talk about cranial anomalies, there are a few medical terminologies which you should be familiar with. The first one is cranioschisis. Now, schisis simply means opening or laying apart. So cranioschisis means that during neurulation, if you recall the event, which is the formation of the neural tube, which takes place in the 3rd week of development, that is neurulation, there is a closure of the neural folds to form the brain and the spinal cord. Well, if the cranial neuropore fails to close, then that can cause the abnormal formation of the cranial vault. So if the cranial vault is not formed, that is the top and sides of the skull is absent, that is acrania, that can cause the exposure of the brain tissue to the macerating, that is the harmful effects of amniotic fluid, and that will cause erosion of the brain tissue, the necrosis of the brain tissue, and then this condition is known as anencephaly, and it is incompatible with life. Then there could be less severe form in which there is only a certain gap in the cranial region of the neural tube and the skull. So if there is a gap over here in a cranial region, a gap or a deficit, then the meningeal layer that might extrude or herniate through this gap, causing the appearance of a sac, which is known as meningocele. And if the sac also contains brain tissue within it, then it is called meningoencephalocele. Another terminology, which is merencephaly. In case of merencephaly, partial brain tissue is present, but when there is a total loss of brain tissue, remember that is anencephaly. Now we come to the craniosynostosis. Now, craniosynostosis, this is a group of anomalies in which there is SYN. Syn means fusion, and ostosis, that represents the bones. So this is basically a group of different presentations in which the primary underlying defect is that there is a premature closure of one or more sutures. If you recall the discussion on sutures, we saw that the sutures were the fibrous joints containing the dense connective tissue present between the flat bones of the skull. And these sutures, they are replaced by osseous tissue, or you could say there is permanent closure of the sutures at different time periods after birth. Now, if they either of those sutures close or become permanently fused before their normal time period, that is the premature closure of one or more of the sutures, that can cause to an abnormal shape of the head, And this condition is collectively known as craniosynostosis. And there are different types of craniosynostosis, which we'll be just going into the detail of that. Keep this in mind, this is a feature of more than 100 genetic syndromes. Primarily, it involves the defect is in the interaction between the neural crest cells and the mesodermal cells boundaries. We know that these were the two basic embryological cell populations forming the cranium, the neural crest cells and paraxial mesoderm. So if there is some abnormality in the interaction between these two cell populations, this can cause the craniosynostosis. The first type of craniosynostosis is scaphocephaly. Scaphocephaly occurs when there is early closure of the sagittal suture. If you recall, this was the suture present in the vertical midline plane between the two plates of parietal bones. If this suture closes prematurely, then this will give rise to a skull shape in which the skull is long and narrow with expansion in the frontal, that is anterior, and occipital, that is posterior regions. So here is a simple diagram showing us the comparison. A is a normal baby, a baby with a normal shape of the head, and in B you can see is the baby with scaphocephaly. So you can see the skull is long and narrow, and there's a frontal expansion and there is a occipital expansion. If we look at this baby skull from above and compare it with the normal skull, we can see that in case of craniosynostosis, which is scaphocephaly, there is premature closure of this sagittal suture, and this causes the brain growth will take place, and it will cause the compensated expansion in the anterior and the posterior directions, leading to a long and narrow skull, which is known as scaphocephaly. The other condition or other type of craniosynostosis can occur due to early closure of the coronal suture. Now, the coronal suture, if you recall, was present between the frontal bone anteriorly and the two parietal bones posteriorly. And this is a suture which was present in the coronal plane. Its early closure can cause brachycephaly. In case of brachycephaly, the shape of the skull is such that it is wider from side to side and it is decreased in length anteroposteriorly. So here you can see the bilateral coronal craniosynostosis. This was the coronal suture and it has prematurely closed on either side. And over here, if you look at the skull from above, here is the normal skull. This is the coronal suture present between the frontal and the parietal bones. But over here, in case of brachycephaly, premature closure of this coronal suture has produced a skull which is rounded and it is wide in the lateral direction, but not anteriorly or posteriorly. Another type of craniosynostosis is plagiocephaly. Plagiocephaly is the condition, the skull shape, which results when the coronal suture of only one side closes at an earlier time. And this causes an asymmetrical flattening of the skull. So here you can see plagiocephaly. Let's look at this view of the skull from above. And we can see on the left side, there has been early closure of the coronal suture. And this has produced the flattening of the skull over here on the left side, which is evident as you can see the shape of the head of the baby from the anterior aspect. You can see that this here is the one-sided or asymmetrical flattening of the skull. So this condition is known as plagiocephaly. A quick comparison of these different abnormalities of the skull shape with the normal, then we can see the plagiocephaly, the skull has been flattened on one side. In brachiocephaly, it is broader from side to side, and in scaphocephaly, it is broader in the anterior and posterior direction. So you can see the frontal bossing, or you could say the prominence of the forehead in case of scaphocephaly. Generally speaking, what are the causes of these different types of craniosynostosis? Well, there are multiple factors involved, but the most common cause are the genetic level, the mutations which occur at the genetic level, which can cause these different conditions. But environmental factors also play a role, such as the deficiency of vitamin D or other factors which are exposure of the mother to these anticonvulsant drugs like diphenylhydantoin, valproic acid, or exposure to the drugs which are methotrexate, cyclophosphamide given in cancer therapy, or retinoids, which are vitamin A derivatives. So exposure to different drugs, that they can act as teratogens and they can have a role in causing the different types of craniosynostosis. And there are also certain physical factors involved, like if there's a decreased space or capacity within the uterine cavity due to decreased amount of amniotic fluid, that is oligohydramnios, or because of multiple pregnancies, that can cause the compression effects on the skull and cause the abnormal shape of the head. Another clinical condition that I would like to discuss in this topic is thanatophoric dysplasia. This is the most common form of lethal neonatal dysplasia, and this is a skeletal dysplasia. There is maldevelopment of the skeletal system, and in this case, there's a characteristic shape in specifically the type 2 form of thanatophoric dysplasia. This characteristic shape of the head, which is known as clover leaf skull. Clover leaf skull occurs when all of the sutures, they are closed prematurely. So you can see over here that this is the clover leaf skull in case of thanatophoric dysplasia. Along with this, I would also like to mention another clinical condition, which is the achondroplasia. You might have heard of that before. You know about dwarfism. You might have heard about the different types of dwarfism. Well, achondroplasia is the most common form of skeletal dysplasia, which is compatible with life. And this leads to a form of dwarfism in which there is going to be an abnormal shape of the head. That is, there will be a large skull, which is known as megalocephaly, but a small midface, the extremities, that is, the limbs will be short, the fingers are short, and the abdomen is protruding. This is inherited as an autosomal dominant disorder, and 90% of the cases, they appear sporadically due to new mutations. So here is a 9-year-old child with achondroplasia, and you can see over here that there are short extremities and short fingers, protruding abdomen. And if you look at the head, the shape is larger than typically a normal head would be. And you can see the frontal bossing, that is the prominence of the forehead. Another clinical condition is cleidocranial dysostosis. This is an example of generalized skeletal dysplasia in which there is a late closure of the fontanelles and decreased mineralization, or you could say the ossification of cranial sutures. So this results also in an enlargement of the head, specifically bossing of the frontal, parietal, and occipital bone. So bossing means an abnormal protuberance and an abnormal appearance, that is the prominence, abnormal prominence of these bones. And in this baby over here, you can see that the clavicles are also absent. So they're underdeveloped or absent clavicles, causing the name, that is cleidocranial dysostosis. So this was today's topic of discussion, in which we talked about the development of the skull. And we went into a little detail of the formation of the skull regarding the different parts of the skull, which were neurocranium and the viscerocranium. And we also discussed the clinical abnormalities related to the abnormal shape, leading to the abnormal shapes of the head. So if you found today's topic interesting and it was enlightening for you, it made it easier for you to understand all the aspects of skull development, then please like and subscribe to my YouTube channel, which is AnatomyMentor. And you can do that just by pressing on my picture, which is going to be appearing at the end of this video presentation. And also don't forget to press the bell icon to get the notifications for my video lectures and my different topics of presentation. So thank you and take care. And till we meet again, I'll be coming with the new lectures and new topics. So take care and enjoy your studying.